27 years old female patient complaining of heartburn, nausea, vomiting for 6 years duration. Symptoms increased in the last year. Patient is now under treatment with proton pump inhibitors. Upper endoscopy showed grade 3 reflux esophagitis. Her motility study showed low LES resting pressure, low esophageal peristaltic wave and duration.
So good afternoon, ladies and gentlemen. So we will start this procedure, which is one of the various experimental treatments which are proposed for patients with GERD. You know, you heard about suture, and probably you heard about this technique, which is the injection of the polymer into the lower esophageal sphincter. The particularity of this technique, because you probably know that injection technique has been attempted many times in the 80s with incomplete results, especially at midterm. We're using either collagen, and Glenn Lehman was one of the pioneers in that, but he was disappointed with the midterm results. And then with Teflon, I think there have been some publication also from Egypt with Teflon injection, but you know that Teflon is very difficult to inject. And this material that we will use here, we will later on, maybe tomorrow morning, show you a demonstration of the material itself. But it's a polymer, it's a biopolymer, which is completely inert. And the name of the substance is, the trade name is Enterix, but the name of the substance is acetyl vinyl alcohol, which is used also in neuroradiology for embolization of pseudoaneurysm. And it has the particularity of being a fluid, which is black, as you can see in my hand. It's very fluid, so it's very easy to inject, and it's black, and it's radio-opaque. This is the advantage of these two particularities, is that the material is black, so you see it endoscopically, and it's radio-opaque, so when you work under fluoroscopy, you can see the material on the fluoroscopy too. So there is no question to do this kind of procedure at the present time on a routine basis. There are still protocols which are ongoing, and the first study that we have published will be published by the end of the year in GI endoscopy. There is a FDA trial which is finished, but we still have to consider that it's an experimental technique which should be performed in the setting of control study, or at least like we do here, after the agreement of the patient, and being sure that the patient will be followed after that carefully. The technical point which has changed in comparison with the other techniques is that we do not try to inject the material in the submucosa. You know as well as I know that if you inject something in the submucosa, there will be slugging of the material into the lumen of the digestive tract, and the material will disappear. This is probably the reason why the Teflon injection or the collagen injection have been disappointing, because they were injected in the submucosa. Just like when you inject histoacryl in a varice, you know that after some time you will have a complete disappearance of the material which slow into the digestive tract. And when we start the really first patient, we had the chance to do the first patient in Belgium with this material, we decide to try to get an injection into the muscle. So you will see during this procedure that the purpose is to put a needle, which is a specially designed needle with a 4 millimeter length, to impact the needle level with the cardia, and to avoid to see bulging of black material, because if you see the bulging of the black material, it means that you are in the submucosa, but also to follow on the fluoroscopy, and you need a high quality fluoroscopy to be sure that you are not injecting outside the esophagus. So we will start. This young lady, I would like to add something which is, I think, very important, is that there is a major difference between the management of these patients and the usual management we do with gastroenterology patients. When you have a patient with a common bile duct stones, with cholangitis, or with a pancreatic cancer, of course you have to do something because the patient is sick. Now we are dealing with patients who are like you and me, and who have only heartburn. So it's the reason why I'm very careful when I do this kind of procedure, which can seem to be simple, but it's not so simple on a technical point of view. And moreover, we have always to keep in mind that we are not allowed to have complication with this patient. These patients are normal patients who do this treatment just for comfort, and of course we cannot afford for the rate of complication we can usually accept with standard therapeutic endoscopy. So I'm using a forward viewing scope, but you can also use a side viewing scope for this kind of treatment. And we are, Horst Neuhaus is entering the room, is the one who has also a large experience in this kind of treatment, because the European protocol was performed mainly in our 2 centers. So you see that I'm coming in the esophagus, looking at the squamous junction, the Z line. This patient has had a manometry before, showing that the resting pressure of the lower esophageal sphincter was low. So we are sucking a little bit the fluid